All right, well, greetings. And I'm Margaret Helton. I'm serving as the interim chair. I've had the privilege of serving as interim chair since the summer when my predecessor got a little promotion. You see her in the back there. But a warm welcome to all of you back to Chapel Hill to our Alumni and Friends Weekend. It's wonderful to see alumni and colleagues and students and members of our patient advisory committee and friends with us here today. As a leading academic department, it's our mission to discover and disseminate helpful ideas and staying connected to our alumni, as well as to learners and members of our own healthcare community, is an important way to ponder, discuss, and share those new ideas as we seek to improve and advance the health of our patients statewide and nationally. This is especially important in this time of dramatic and uncharted change, especially in North Carolina, which is considered by many to be ground zero in healthcare transformation. These changes are disruptive and can feel threatening, but they also provide opportunities to advocate for core family medicine values, such as continuity, comprehensiveness, behavioral health, and cost effectiveness. The theme to our conference this weekend is a roadmap to value-based care. And this roadmap is not one you can punch into your phone and get GPS lead you through well-described and documented streets and highways. Rather, a better analogy would be it's like charting and settling a new world where no one has gone before. Successful navigation will require people who are willing to challenge the current paradigm and lead us in a new way that is understandable and sustainable. And that is why this weekend so appropriately starts with the John T Henley lecture. I'll tell you a little bit about John Henley. In 1946, John Henley opened a pharmacy in Hope Mills, North Carolina, a small town where he also served as mayor. He observed patients going to the hospital for treatment that should have been provided by a primary care provider. And he saw patients coming into his drugstore with medicines that they didn't need. Serving first as a representative in the North Carolina House, and then as senator, John Henley wrote the bill that mandated the creation of the UNC Department of Family Medicine. And that's an actual picture of that bill, which was passed in 1969, much to the shock of leadership at UNC School of Medicine and the university, who did not see what was called family practice at the time as worthy of establishment in an academic medical center that was otherwise focused on specialty care and training. But that bold leadership and vision created our UNC Department of Family Medicine, which has a nearly 50-year history of training family physicians, medical students, behavioral medicine providers, social workers, pharmacists, health administrators, and researchers who are invested in the well-being of the people of North Carolina. UNC Family Medicine is consistently viewed as one of the top departments of family medicine in the nation. Senator Henley's advocacy for primary care was not limited to UNC. He served on the Health Manpower Commission, which led to the creation of ECU School of Medicine, again mandated by the North Carolina legislature, and again over the objections of the established academic community. Senator Henley's vision, leadership, and advocacy established and promoted family medicine in North Carolina. If not for him, our state would have a severe shortage of access to primary care. Senator Henley did not seek personal recognition or gain. Rather, he served to improve the future for the people of North Carolina, and it's appropriate that we honor him and carry on his legacy. Before Dr. Goldstein introduces our Henley lecturer, it's important to recognize a few people. First, joining us is Dr. Ed Shahady, who is the chair. You'll be hearing more about Dr. Shahady this weekend. But Dr. Shahady was our chair emeritus of UNC Family Medicine, and his leadership was crucial during the formative, critical early years of this department. And he was instrumental in building a strong foundation on which this department rests. He played a key role in the building of this building that we are currently sitting in, which gave us the independence and identity to thrive, and that has shaped our department. Second, I want to acknowledge this weekend's co-chairs, Drs. Dana Newts and Amir Barzan, for organizing this conference. Is still down in clinic, so they will make an appearance, I promise. Finally, I'd like to recognize the specially selected John Henley Award recipients. These medical students are not just interested in family medicine, they are interested in leadership in family medicine. And the Henley Endowment is providing funding for their attendance here this weekend. And will you please stand? Now, Adam Goldstein, our Director of Advancement in the department, will introduce our speaker. And thank you to Dr. Goldstein, who worked with the Henley family to identify and recruit this year's speaker.
Thank you, Margaret. It's interesting as we think about the topic that we picked for this weekend about value-based care. It's one, we picked this over a year ago, almost a year and a half ago, when we began thinking about what do we need to know, because it's something if we're thrilled and excited about, we hope others are too. And so we picked things that we just didn't know enough about, and how do we learn together as a community. One of the things Margaret mentioned about the birth of family medicine is that family medicine came out of counterculture and really trying to be that force that moved and became into culture. And I think the last 5-10 years, we would say, well, we're so accepted within that healthcare system. What is counterculture now? Well, maybe value-based care is a little bit of counterculture being willing. And when we decided to do this topic, and we wanted to find out who might be one of the people that we really could bring in that can really reflect on what's happening nationally, be a lens through which we can see anything that we're doing. Dr. Lee Mills was the person. Dr. Doug Henley said, there's one person I want you to go after. I want you to talk to Dr. Mills. You really can see his bio and CV in your packets there. And there are a couple things that really struck me as to why he is the right person here. Well, first off, he is a family physician. And so if you look at the leadership, and many of you know Dr. Gwynn, who's really one of the leader within the UNC healthcare system, family physicians who are working and leading in this movement. And he's doing this in Oklahoma and Kansas and the Midwest, really the same kind of daily things that we probably are going through. So it's that lens of which us to understand. And second of all, he's got family, just like in family medicine, and value and important. And his brother's a family physician. Went to Wake Forest and North Carolina roots there. The third is connections with the American Academy. I know we have representatives from North Carolina Academy here. It's important that we understand in the organizations that which we work. And the last thing is, when I called him up and said, I'd like to be able to do this, but I have to report for reserve duty, and I think it's the day after the talk or 2 days after the talk, and it's going to be 4 months. And yet, a couple days later, he said, I really would love to come. And so his service to others, the service to the military, each one of these, we really could say thank you in total willing to come here, spend time, and help us and be our Henley lecturer. So thank you so very much.
Well, Abby, thank you for that beautiful introduction, and Dr. Hilton for the event and the opportunity. When I was talking with Dr. Henley at his beautiful office in Kansas City about this opportunity, I did remind him that he already knew better and that he would, at some time in the future, regret having provided this opportunity or name. But we're going to have fun today anyway. So this is a wonderful conference, and I've just enjoyed reading about the proposed talks, and a roadmap to value-based care is precisely what we need now, because we're aware that the road is changing. We're all busy trying to change our practices, trying to change the tires on a new car moving down the highway, right? We don't have the luxury of stopping clinical care for 6 months to hook it back together differently, and that's a challenge for all of us. And so I love this concept, and I think it's going to be a great lecture, or a great conference today. Now, I want to say a couple things just to get started here at UNC, which is I am not an academician. I have published a few things. I was a clinical associate professor, clinical professor for Dr. Kellerman at KU during my practice in Kansas. I love teaching, but I'm neither a professional teacher nor an academician or a researcher. I am merely a journeyer like you all on this road. And somewhere along the way, I realized that though I really loved taking care of patients, and we'll talk about that, I also love the complexities of trying to build a better healthcare system for my partners and my patients who are struggling every day with all those things that we deal with, formularies, and the EHR doesn't work right, and phone calls aren't being returned timely, and all those operational things became interesting, and I moved into that area. So I especially appreciate the opportunity to give a Henley lecture, and as I read about John and talked with Doug about him, I think John would love where we are today. He would see what's going on today. He would bring together a coalition. He would use the machinery of government and organized civic leaders to build a coalition and to do the right thing for patients for our communities. And I propose to you that is precisely where we find ourselves in value-based care. And those types of structural changes going on around us every day right now. We'll say a little bit about me, just so I also agree with Dr. Helton's reference to a lens. I have a very specific lens, and I'll admit that, and it's probably not the same lens most of you all see practice through. So I was in private practice for nearly 20 years in rural Kansas, a town of 20,000 people. I did my own hospital work, ICU work, floated my own swans back when we still did that, delivered babies for 11 years before my own kids were old enough to make that a challenge. And then I started moving into organizational leadership, got a master's at Carnegie Mellon, and all those sorts of things. But I am fundamentally, to my DNA makeup, my bones, a family doctor, which is what I wanted to be since I was 6 years old. My brother was going to be an Indian because that was a vocation, and I was going to be a family doctor. It never changed. He went through firefighter and Air Force pilot. I was dead set on being a family doctor, and we don't really know why. I do have a little bit of connection to North Carolina. In my formative years as a resident, Jim Jones and his lovely wife Michelle and I are resident leaders at AFP together. I've served in a whole variety with Conrad Flick and a whole variety of endeavors, including the AMA Rock over the years. And I did go on a little 2.5-week backpacking jaunt on a little trail that runs through the hills west of here with a young lady. Back in college, I wound up having 3 kids with her, so it was really good. It was a really good trip. Though it started raining, we passed Memphis, and it didn't quit raining for 2.5 weeks. Currently, I'm a medical director at Ascension St. John, which is part of Ascension. So Ascension owns 28 health systems. It's the largest not-for-profit healthcare organization in the country and the largest Catholic health organization in the world. St. John is a 6-hospital system in northeastern Oklahoma, as you see. We have a 600, I'm a medical director, one of 2 operational medical directors for a 600-position primary care, 600-position multi-specialty group, right? It's about 150 primary care providers. We cover 25 different clinics from southern Kansas all the way through southeastern Oklahoma. 170,000 patients impaneled that our primary care teams take care of. And we have been embarked on this value-based care effort since the Comprehensive Primary Care Initiative began in 2007. So we were one of the first 7 small geographies was the Tulsa metro area. So we've been embarked on this now going on 10 years. And I think we're doing it reasonably well, not perfect, but we've learned some things along the way. My clinic sites are all in Comprehensive Primary Care Plus. And I think that's an important lens I see this through, because in terms of nationwide scope, Comprehensive Primary Care Plus is the game in town for operational value-based care, bringing you new revenue today to hook things up differently, right? Half of my group is also in an ACO, in a multiple shared savings model, which has been interesting. And then lastly, my health system owns Community Care, which is Community Care Managed Healthcare Plans of Oklahoma. It's the #1 Medicare Advantage insurer in Oklahoma. And I sit on the board of directors for that. So I see the lens of value-based care from a provider seeing patients, to an organizing force inside a large health system, all the way to an insurer lens looking at coverage of healthcare for a state. I have in the past been medical director at long-term care facilities. I'm boarded in hospice and palliative care. I'm an Army physician, and I do report for my 6th mobilization in my 21 years in the Army. On Sunday, I drive to Fort Hood, Texas to spend a couple of glorious months. Served on the RUC for 12 years, which is kind of a doctoral course in high-level organized medical politics and payment policy. Proud family man of 3 teenage boys. That one is, the oldest one is a sophomore in college. This one, that one was a senior in high school, just named a National Merit Scholar. And that one continues to be a force to be reckoned with, is in 9th grade. And then husband of a wife that I clearly do not deserve. Leave it at that. So what we're going to do today is go on a journey. So the itinerary is to just make about 7 stops and talk about 7 observations, 7 viewpoints, if you would, that reflect on our journey towards value-based care. And I guarantee only 2 things. One is that there's somebody in this room, given that it's UNC, there's somebody in this room that is more expert than I am about what I'm talking about every single stop. And that's okay. That should lead to some fun questions and conversations. The second thing I can guarantee is that these waypoints are constantly shifting and changing. So my perspective, my thoughts, my observations that I'm making today may be completely different a year from now and 3 years from now. But that's the nature of the journey, right, as we experience. So most of what I've learned, and I'll ask to say don't consider myself an expert in this. I'm just a worker bee trying hard to build the best healthcare system for my community that I can possibly, and I know that drives each of you as well. So I want to let this sink in. Some of you have probably seen this before. This was an architectural wonder of its day, the most best engineered bridge meant to sustain a Category 5 hurricane that had ever been built. It's in Honduras. And in 1997, Hurricane Mitch came. And Hurricane Mitch dropped nearly 90 inches of rain in 4 days. And the river moved. That is where we are in healthcare. And that means something really, just let that feeling soak in. Because every day I go to work, Dr. Goldstein asked, what's it like for a day for you? Every day I go to work, excited and scared, flip sides of the same coin, that healthcare has moved. And we have tremendous opportunity, and family medicine is poised to surge forward and take full fruition and full ownership of our position in the healthcare system that's been needed for 40 years. And also scared because there is so much inertia, there is so much complexity. There are active things dragging back the changes we need to make, including at a personal level for each of us. So, no, this is the most important lens I see our work through. The river has moved, and it's no use complaining about it. It's only about adapting and moving forward. Okay, so some definitions that I'll use. First of all, patient-centered medical home and advanced primary care aren't the goal. They're the delivery system. They're organizational constructs. They're a step past the doc plus one, the old private practice model of me and my nurse did everything every day. I practiced in that world, as some of the doctors in the room did. Well, PCMH, the step beyond that, advanced primary care, are how you deliver care headed towards a value-based world. Population health is what you deliver. And that's amazing care for the patient in front of you. It's also amazing care of the 2,000 patients you didn't see today in the exam room, simultaneously all at the same time. And lastly, value-based care is essentially why you deliver it. And I know we can have a fun conversation quibbling about how I characterize those, but it's as good a construct as any. Value-based care is the triple aim in action. It's better care proven at a lower cost and a better experience for patients that are involved. Because if we don't provide a better experience, patients will go a place they get that better experience. And that's consumerism in action. That's part of the evolution in healthcare today. So observation number one, we are being disrupted. Dr. Helton referred to that. This is a really important lens and important construct that fits right with the river has moved. And this is an example of disruption. There have been more high-resolution photographs taken on smartphones in the last 2 years. Numbers estimate between 2 and 3 trillion pictures. More smartphone pictures in the last 2 years than in every plate and film camera ever produced in history. That's disruption. The largest hotelier, the largest hotel organizer doesn't own any real estate, and that's Airbnb. The largest transportation taxi company in the world is Uber. They don't own a single car, right? That is happening in healthcare. And in healthcare, all of us in this room, and we're the New York taxi cab companies that are being disrupted, right? We're Kodak, and that means something pretty deep. Clayton Christensen is someone I'd like to refer everybody to. As I studied for my Master's in Management and really got into leadership medicine, Clayton's book, which is nearly 25 years old now, Innovator's Prescription, was one of the most significant, or really I'd say the most significant work that I read to help understand what are the moving currents driving us forward and what are the possible outcomes. And it's kind of remarkable that from the lens of a Harvard Business School professor, he predicted what we're going through 25 years ago. And I think the choices of what, as you squeeze a balloon at the fair, little pieces pooch out, and you can tie it into a dog. He predicted what pieces we're going to squeeze out 25 years ago, and he's remained remarkably accurate. So he defined what disruptive innovation is. It is not something that you can resist. It's not like you can get a timeout, and we're moving through it now. And the focal point of disruptive innovation is our customer doesn't want what we're selling right now. So 80% of healthcare decision making is made by mothers and wives in the family unit, 80%. And what she wants isn't what we have to offer by and large. It's not an appointment next Tuesday that will be an hour late for, that will take you an hour to get in, that will cost you, $20 copay plus $85 for really 2 fairly simple questions, right? One medicine refill for controlled hypertension or OCP or what have you, and something to look at. What she wants is much less about expertise, our expertise, and continuity than she's looking for convenience, timeliness, relationship, communication, and engagement. And that means really, really deep things for how we organize our healthcare system at the clinic level. So this is another way to say where do we find ourselves, which is absolutely it's a lousy fit, but the quality is terrific. Absolutely, we're inefficient and slow and behind and too expensive, but you're going to keep coming because we're the best, right? We always go to quality. And what I'll say to you about this is quality is not a winning argument in the disruption of healthcare. Quality is assumed, right? There is no better way to lose your patients and to develop a reputation for poor quality. But when patients are coming, they're assuming they're getting quality for what they want. And here's the kicker, defined the way they define it, not the way we want to define it, right? And now I'm going to read this, the Patient to Consumer Revolution, Oliver Wyman in 2014. The transformation of U.S. healthcare is the biggest business opportunity in our lifetime. It also presents enormous risks. As leaders in healthcare organizations who still believe they're preparing for continued growth of volume, and they're raising capital to build new things. I can't make that move. Sorry. The executives are falling into a familiar trap. They know the world is changing. They believe they're an exception, can continue to do what they've always done before. Ask them why they don't rush to take advantage of new opportunities or build new capabilities to replace the inevitable change, and they'll say something about their quality and excellence of care. And that continues to be true. And I hear this a lot. I hear this, we talk about why does the health system, meetings I'm in, all the MRIs and the PET scans are in the mothership. Parking is a disaster. Waits are long. Just getting in the elevator can wait 15 minutes. Why don't we move PET and MRI to an ambulatory outpatient service center 3 miles away? Well, it's because this is quality. This is the best. People will come to us for the service, and they're not. So the disruption script that Clayton defined is the incumbents. We continue to provide a product we're comfortable selling, what we've done. We focus efforts on continuing to improve physician capacities, meaning we continue to buy faster scanners, more slices, we put in another machine. We invest in continued iterations of the stuff we've always done, right? We're pretty secure in our self-perceived moat. Well, Duke thinks they've got the healthcare system, but really ours is the best, and we'll keep doing that. And we're a bastion of expertise and quality. People will come to us. What the innovators do, and this, again, let this soak in. Innovators connect consumers, patients, with something the patient wants. What the patient wants is a simple way to understand their diabetes and get feedback on what to do with their medicine. Not next Tuesday after waiting an hour. They need that right now at 2 a.m., just like you deposit checks with your bank. And there are services doing that right now, very effectively. The innovators effectively and cheaply provide what a consumer wants. Quality is presumed, good enough quality for what the patient wanted. The cost is very transparent. They know every time what they're getting for what they're paying. That's the definition of value, whether you're talking about cheeseburger or healthcare, what you got and what you paid. And these innovators do only a few things, but they do it really, really well, right? That's about as diametrically opposed to a modern large healthcare system as anything I can think of. And this is how Clayton Christensen talks about it working. So we have axes of performance, established industries, and this has happened in healthcare. I mean, it's happened in automobiles. It's happened in air travel. It's happened in manufacturing and car manufacturing. This cycle has been proven through history going back 60 years in multiple industries. Actually, healthcare is the only major dominant industry in the economy that's not gone through one of these disruption cycles. The established players continue doing sustaining innovations, improve on what they've done until they wind up with a capability and product hugely past what any of their customers need most days, and at a cost point no one wants to pay anymore. An innovator, a disruptive innovator, drops to the bottom, makes a very simple product cheaply that does one thing really, really well. Then as they gain customers, they build new capabilities and go upstream until, boom, right there. Suddenly they're providing a product and a service that performs what most customers really want, and all these customers drop to the new consumer. And that's happening to us. There's a whole lot of science and a whole lot of math behind this in the book. I'd recommend you read. Part of our problem is, and everybody's familiar with this is, I think, a seminal work in family medicine, is we built our entire care delivery system on these 10 patients. We did a really poor job of paying attention in general to the 25% of patients that just have a simple need, right? And we ignored the 750 patients that don't come to the office, that still have questions. They still want to know, Tylenol's not working for my daughter's fever, what do I do? Okay, that shouldn't be an office visit. It just shouldn't. So I think partly, and this is an old study redone more recently in 2001, but I think what we're experiencing now is this coming to rest. Now, I know that's a little provocative, but I'll say things that are provocative, again, to kind of jar us out of our mental framework. Here at Academic Health Center, I'm not saying this is not critically important. I'm absolutely saying that. We will still need radiologists and neurosurgeons 20 years from now. But what I am saying is the entire care delivery system can't be built around those 10 patients, or else someone will deliver services to the other 990, and that is happening. So in primary care, lots of disruptors. We're all familiar with a lot of this. First of all, something Dr. Christensen really said that helped me understand my work a little bit better is primary care, unlike a specialty care, primary care is 3 distinct services simultaneously. It's acute care, it's wellness and preventative care, and it's chronic disease management. If you think about how to optimize any one of those, they would be very distinct. They would have different physical structures and office layouts, have different staffing, different numbers, different types of people, have different informations, would have different workflows. And yet we're trying to do all 3 service lines in the same office with the same staff and the same 15 or 20 or 30-minute schedule framework, right? No wonder we're not terribly efficient or effective. Systems are efficient, people are effective at doing any of those particularly well, right? Our location is varied. Our workflows are varied. If you go to, in a 5-mile radius, if you go to 10 primary care clinics, you would have 10 very different experiences. Our cost is basically moderate to high, and our service to the customer is poor to moderate, most of the time, in general. And I realize I'm painting a really broad brush. I'm sure none of that applies here at the Family Medicine Center at UPC. Whereas clearly all that's true. So I should say, my brother went to Wake Forest. His goal was to get as far from Oklahoma as he could, and he stopped at the ocean, headed east. I am by blood oath, I must dislike Duke, so that's where I'm at. All these disruptors, retail, urgent care, workplace clinics, wellness clinics or medical spa. Does anybody have a pounding migraine when the patient comes back from the medical spa and tells you all the things they tried to do? Well, yes, and yet they're filling a need. Online health communities. I think we have a tremendous opportunity to latch onto that and take hold and embrace it. In disease specialty clinics and wearable tech. I think we're barely seeing where wearable tech is going to go. And Amazon and Google are going to be doing some pretty amazingly disruptive things in that space. Part of our problem, again, 3 distinct service lines in the same structure, simultaneously the same providers every day. We know that it should take 21 hours for a single provider to provide all the care 2,000 patients need. And I'm pretty dedicated, and I am willing to work 14 hours every day, but I'm not willing to work 21. And so unless we build structure different, for every provider with a panel of 2,000 patients, we're accepting de novo that we are just not meeting all my patients' preventative needs. We're not meeting all the acute care needs, which means they're going to the ED, or they're going to the competing urgent care down the street, right? And my patients with chronic disease are not getting the care they need because I don't have time to focus on it. I can't do it all. And so I think some of this sees why acute care and family medicine is really struggling and splintering off towards an urgent care service line, both within systems as well as in our practices. We do have an opportunity to do that inside our own practice, but that's a different pod, structured differently, set up differently, staffed differently. Okay, observation number 2. Value is in the eye of the beholder. And, I wanted to put a picture to David and say it's just like beauty. Perspective is amazing. And I find myself in conversations at a health insurer board level or in my health system leadership councils, realizing a lot of our cross-conversation past each other, we're using the same words and mean very, very different things. And my perspective organizing ambulatory care systems and the hospital president's perspective of advertising immediate seating available in the emergency department, like a neon sign, right, goes off in all the Walmart parking lots when they need to bring some patients in, are different. Our hearts are in the right place. We're pushing the same direction. We have very different perspectives. And just as you engage your day-to-day life with colleagues, just remember that. So value, first of all, realize value is at multiple levels. Here in a family medicine center with leadership in organized family medicine, we're really focused on delivery of care. Real doctors, real nurses, real patients, right? That's the value delivery we're used to, right? But value also is in the revenue stream, how money flows in. That's not see a patient, bill a patient, see a widget, bill for a widget. In clinic budgeting, right? New experiment here underway in that sense of value. Provider compensation, I think, is going to be probably the last domino to fall to make it all click together like Legos. Expectations and culture, that's my biggest fear. I'll come back to that in a little bit. And then benefit design from the payer level. If you're paying, your fee schedule is still a fee for service, it's going to be hard to get better care outcomes that you want. North Carolina is actually, I think, led, as I've followed the research over the years, from the Asheville Project about getting pharmacists contributing to primary care to North Carolina, we call it community care program from 15, 20 years ago, to right now, you've got experiments in Blue Cross and Medicaid. The state chamber has a roadmap to value-based care. North Carolina is doing some really cool things, I think, leading in the concept of payment benefit design. So, multiple levels. First of all, from the purchaser, from the employer. So this is government and the employer. When they say value-based care, what they mean is they want a predictable budget. They know what it's going to cost and not have it be 20% higher at the end of the budget year. And quality is assumed. I'm paying for it. I'm going to get decent quality, and we'll find somebody who'll do that, right? From the payer level, this is the insurer level, they're expecting, when they say value, they mean decreased cost. It needs to cost us less next year and the year after that, and quality, whatever it is, needs to get a little bit better. Because in general, our provable quality is not great, written large. From a health system perspective, value means not just fee for service, it's an alternate revenue stream, different source of money, right? And it means decreased costs. Value means we're doing stuff differently. Instead of staffing all these expensive doctors, we're going to have 20% of our patients cared for by the care manager at a lower cost point, right? So it's alternate revenue and decreased costs. For a physician, it means improved patient care, a little bit better workflow and job life, and maybe some extra revenue. Mainly family medicine salaries will rise to our value in health ecology, right? And for a patient, value means self-defined access. It burns in my pee and I'd like to have my diabetes checked on and I want to come at 2 o'clock. And I am absolutely expecting that. And if you can't do it in your clinic, I'll go someplace that will do that. And they're expecting lower costs, however they define that. So just be aware, in value, there is a whole lot of perspectives that change. You got to be sure you're talking not past each other, but mean the same thing. So here at St. John Ascension, I just did kind of analysis that our purchasers, meaning our businesses and the government, they're still paying a flat premium. Now, in the future, will premiums be flat? I don't think so. I think if you're a overweight, diabetic smoker, probably your premium is going to be a higher cost point than a 20-year-old healthy male that doesn't ever go to healthcare unless it's dangling or bleeding from an artery, right? So there's some laws preventing that, and it kind of goes against the basic concept of insurance, but I do think we'll see flat premiums dividing in different ways in the future. In Oklahoma, payers, however, are really to embrace this. We've got fee-for-service, we have monthly care management fees for CPC Plus, every month, risk-adjusted, per member per month, paid to the practice to care for those patients all the time when they don't come in. And then we have both incentive-based payments through community care, through CPC Plus, and shared savings through our ACO potential. And then we have capitated payments from our Medicare Advantage payers. So we have a wide river with multiple tributaries of revenue coming in addition to fee-for-service. It actually, primary care's revenue stream is 55% fee-for-service, 45% everything else. In CPC Plus, however, the Track 2 sites and more advanced sites actually took 60% of their predicted CPC Plus fee-for-service payments and turned it into a per member per month payment that adjusts once a year. So when you figure that into, we're actually earning less than 50% of our revenue from see a patient, bill a patient right now. From the physician compensation level, we're still 85% fee for service, 15% quality metrics, panel size, APP supervision. We're pushing that. There's a roadmap. This goes down over time. That part goes up over time. There's all kinds of legal and compliance and start considerations that we're just working through and teasing. It's a Gordian knot, jumble of inertia, jumble of laws, and keep picking at it one at a time and move it forward as you can. I think it's critically important, and this is where the academics and the statistical folks in the audience could really help those of us out trying to build systems, is that we need to define value for ourselves. Now, I don't mean value from the decide what you're paying for service. I mean value from the on the ground. How do I prove to our payers and our employers shopping for coverage that my care system, my 180 family docs in 23 locations deliver clear value better than that competing, we should get a higher premium or payment. They should get a lower payment, or they should be cut out of the narrow network. How do you do that, right? Well, the math starts with its quality over cost. That's pretty easy, okay? Quality you can define as outcomes and patient experience. Those are both elements of quality. And that is a pretty, I didn't make this up, that's pretty accepted in the value-based world. And cost is direct costs and indirect costs, okay? Your business folks can tell you what your direct costs of providing care are, what your indirect costs. Realize that indirect costs include wastes. Every time you prescribe amoxicillin for a viral sore throat, that's an indirect cost you shouldn't have borne. Every time you order the MRI for low back pain that wasn't needed, that's a cost that shouldn't be borne, right? So that's how the math starts. Take it a step further. How do you change your compensation? If we're supposed to get paid better for the value we bring, how do you judge? I mean, forget the 170 family docs in my system. Just think about family docs in the state of Oklahoma. How do you really reward people who are doing amazing value, which means you're paying less to somebody who's delivering less value and churning and burning? Well, I took a stab at it a couple of months ago. I've got a real data set from something like 400,000 patient visits, and I'm working on trying to crank this math. Come to find out, when you have a database in Excel, it's 240,000 patient line items long with a bunch of columns, and you ask it to do a scatter plot, it actually chokes so hard you have to reload the software. I'm still working on it. But imagine this, we've got quality, clinical quality, we've got experience, we've got direct costs. I left indirect costs out because it gets a little bit muddy in how do you value the waste, right? There's a way to do that though. So we're going to keep it simple. Hypertension control, breast cancer screening, classic CQ and metrics, right? We're all familiar with those. Experience, how likely to refer friends and family. That's the Net Promoter Score. It's the 8s, 9s, and 10s on a 1 to 10 scale, whether you're doing a survey yourself or PRC is doing it for you, etc. Direct costs, the cost of care, risk adjusted, right? All of my docs patients are sicker than everybody else's, and risk adjustment is how you prove it and quantify it. So if you say that, position one, first of all, as long as you have a goal or you have an expected, you can do an O versus E ratio. Observed versus expected. If you can get everything to a ratio centered around 1, the math works. And how it seems like it works to me is if our goal is 80%, physician 1 did 81%, that's 1.01, O versus E ratio. Same for breast cancer screening. 78%, a bit below the goal of 80%, that's a 0.975 O/E ratio. Experience? Well, our goal is 85% of patients surveyed say 8, 9, or 10, I'd take my family back to this position. Well, 92% did great, 1.08 O/E ratio. Okay, his RAF score is 1.0, cost of care is 845, risk-adjusted cost of care is 820, that's just division. Our goal is to lower our cost of care to 825. Well, that's a 0.99 O/E ratio, right? You have all of this data about what cost of care is average in setting a value-based, our cost is too high, we want to drive it lower. That data is available from payers from a variety of different sources. I know your ACO has it. So in this simple framework, which can be hideously more complex than this, right? You could have 10 quality metrics. You could have waste quantified. Anyway, position 1 has a value ratio of 1.02. He's doing great, way better than average. As I thought this through, I probably have a band of 0.97 to 1.02 is what's expected. This other doc, not as well in the quality, below 1 in the ratio, not as well in the patient surveying, okay? His risk score is lower, his cost of care is higher. When you crank the math, his value score is 0.64. Okay, so that's provocative and feels either threatening or exhilarating, depending on where you live in this space. But we need to define this. It cannot be the health insurers. It cannot be the Chamber of Commerce. It cannot be UNC saying, Dr. Helton, well, we have your data back, and here is your value, right? So I believe this is an area rich for research. I don't have any research basis to put together a system like this. I know each piece of that intimately. And as I've just been trying to do it for my own system, this is the type of construct I've come up with. When you run, I've run it for 20 of my family docs, I would propose to you that the output passes the sniff test. Basically, what I know from my operational directors of getting patients in, what their satisfaction surveys are, what their quality metrics are. It passes the sniff test of, yep, I think he's killing it, and yep, this other doc struggles, long lines, quality metrics not great, doesn't really pay attention to their care manager. That has implications. So I think this is a big importance for us to define our future. Observation number 3, attribution is absolutely everything. And this is something most practicing docs don't have their minds around yet. I mean, at the practicing doc level, attribution means my patients are my patients. That's who's got my name as their PCP in the EHR, right? That's not actually your attributed patients. The circles overlap, and you hope they overlap a lot. But something the ACO experience has taught us is that the patients you think are your patients are seeing a whole lot of other primary care providers as well. Most ACOs, it's a ratio of like 1.8 to 2.2. They saw another primary care doc at a competing system down the street, and you couldn't get them in, or they went to urgent care that counts as PCP. Patients that you think actually saw you, that you think you're their doctor, you saw them once, they saw somebody else 4 times. And patients you've never seen, don't know about, have picked you and told their health insurer you're their PCP, and you're responsible for their cost and outcomes even though you've never seen them, right? They're still attributed to you, right? So all those have implications. So moving forward in value-based care, the importance of billing is going to be subsiding. The importance of attribution is going to rapidly rise up. And this is just kind of crashed through the ceiling in my healthcare system in the last year or 2. Knowing who your attributed patients are is just key to everything. Because the ones that are yours but you don't know it, that's all about outreach and getting them in, right? The ones that are going other places and you don't know it, that's all about making sure that they're trained and educated, they know they can come to see you, and you built the office systems to accommodate them all the time. Whether that's a walk-in track, whether that's half your schedule is built for same-day care, whether it's aggressive use of PAs, all those things are possible. Population health management is all about attribution, right? So the challenge to what we're doing is we've got to take care of room 1, room 2, room 3, room 1 really, really well every day. We also have to take care of all of these people that aren't in room 1 or room 2 today all the time. And that's your team, that's data, all those things are divided up different ways in different systems. But I find my practicing partners are still struggling to get their mind around. It is just important for me to talk to my care manager, my behaviorist, look at my data set, which diabetics are uncontrolled that we haven't seen in 3 months, as it is to take care of room 1. And that's a little unsettling to all of us. We came into primary care to see patients, to touch patients, to see them live. And this is a whole new venue. So attribution usually works like this, from the population health perspective. So first of all, if an insurer requires patients pick a PCP and they pick you, you're their attributed patient. I mean, you're their attributed doctor. You're getting the benefit of their quality and cost, good or bad, whether you know it or not. So it starts with payer attribution. Do you get payer attribution files from your payers? Do you know who they think your patients are? Patient self-identification. They may tell you, they may tell their insurance company. PCP relationship in the EHR, that is important. Patients who say they're your patient, actually you think they're your patient. That's an important layer. Key wellness service. Mrs. Smith hasn't told her insurer. She's seen 3 different doctors over the last year in primary care. Her daughter's family doc at a walk-in center, and an urgent care doctor who happened to be ED, was classified as primary care for that day, right? And one of those docs billed a preventative code. She's that doc's attributed patient, whether they intended to do that or not. Off the next step is, if none of those things have happened, whoever billed the plurality of primary care E&Ms, 9920s, 9921s, 98s, 99s. Whoever billed the most of those in the last year is the attributed doc. In many systems that are more sophisticated go 2 more steps, which is a specialist. Okay, what if a patient with advanced heart failure has seen you and had E&Ms billed, but has seen the cardiologist, for 6 visits? Sometimes they're the cardiologist attributed primary care physician because that's the plurality of their primary care services. Lastly, prescription data. Sometimes it comes down to who's prescribing the metformin. There are certain medicines that clearly are continuity management. And if you're prescribing the antihypertensive, you're prescribing the antidiabetics, You might be that patient's attributed PCP even if you don't know it. This chain can be different for different insurers, right? It gets pretty complex. If this is one insurer, one work stream, you might have 6 or 7 of these lined up across the chart trying to track who your patients are. When we went through this exercise for what our panel said, 170,000 patients. We went through the attribution schema recently based on all the payers using an Optum tool. We had 220,000 attributed patients. That's the data set I mentioned earlier. We only identify 170,000 as our primary care patients, right? So there has been some writing about this in family practice management and other areas. This one is, do you know which patients are yours? It's a pretty good primer. Okay, observation number 4. If attribution is everything, risk adjustment is the rest of everything. Other foundational concepts. So payment is related to resources used. Okay. Patients coming to see Dr. Goldstein are not paying him a $99214, which is valued in this system as whatever it is, $142, because that's what they thought the value was. It's because resource-based relative value system, 1992, says payment is related to the necessary inputs: provider time, provider mental and physical effort, practice expenses, and supplies used. That's the basis of RVRBS, right? Every one of those has an input. It adds up to a total RVU value, right? Well, so in RVS, even transactional payment, fee for service today, is based on what it took to provide the service. For value-based care, it's just moving it from a transactional, every patient retrospectively, I'm saying how much resources this patient used for care, and I'm moving it prospectively to the population level. Same concept, just much, much higher, right? So risk, and it all determines on the basis, is based on risk. So most people are familiar with Medicare HCC, right? The relative adjustment factor, risk adjustment factor. It's scaled from 1.0 as average. So a patient who's 0.5 means their risk of cost next year. It's not quite the same thing as disease severity, disease burden. It's a prediction of cost. It's 50% lower than average. And a 1.1 means it's 10% higher than average, right? That's the risk scale. Well, the reason risk is important, the reason every payer is using a risk adjustment for your patients, whether you know it or not, whether they've told you or not. And from every payer program I've ever been associated with or read about, your quality metrics are usually risk adjusted. Your utilization metrics, how much my patients cost, how much my patient went to the ED, is always risk adjusted, right? Risk adjustment lets you compare apples to apples. Margaret's patients clearly are sicker than my patients because my RAF is 0.8 and her RAF is 1.2. She takes care of old, sick people. It promotes fair payment. The effort and resource to take care of her panel would be more predictable more than my panel, right? It encourages excellent care for clinically ill. It prevents cherry picking, whether it's by a health system or it's by a payer. And lastly, it rewards efficiency. If my average panel size is 1.02, my patients are sicker than average, and I'm doing it less expensively than average, that's the definition of value. I should be rewarded for that, and that's where we're headed. So a lower risk score says your patient is healthier with less risk and cost, or it falsely suggests a healthier population because documentation is inadequate, because there's incomplete coding, or patients were not seen. Realizing what adds up to, there's 10 or 12 standardized risk scoring systems. The one Medicare uses is the one we're familiar with the most. They all use gender, demographics, coded diagnoses. Some of them use combinations, some of them use pharmacy information. There's other stuff, but it's basically what you say the patient has in a coded diagnosis. Okay, so first of all, find your docs in Clinic and Epic who are free texting diagnoses and stomp on them. That's a really bad habit that hurts you. I know in Epic it's probably not possible. They've turned that off, which is great. A higher risk score means your patients are sicker, or they're falsely suggesting it's sicker because you reported diagnosis. You made stuff up. Reported diagnosis you didn't document. Or you're over-documenting because you're a hospitalist and you're just copying and pasting a note 12 days in a row for stuff you didn't actually do. Or you're over-coding incorrectly. So this is all about diagnoses. So we're really familiar, most of us, though we hate it, since 1919, we can tell you how many bullet points it takes to document a detailed history versus a complex, comprehensive history. Well, right now, again, I just told you in my system, more than 50% of revenue is non-fee-for-service. The E&M level drives fee-for-service payment. Our risk score and population size drives all of the non-fee-for-service revenue. And since the diagnoses you place attribute to your data risk and your decision making in fee-for-service, essentially your diagnostic precision, comprehensiveness, complexity of what you put the patient had, including the BKA that is healed and you're not really dealing with it, but it still impacts mobility, you're still thinking about it this year, you got to diagnose that. Your diagnosis complexity touches every payment dollar you get paid this year. It is as important or more important than the 99214 versus 213. And we manage that assiduously, right? So this is just an example from the Medicare Advantage world. 82-year-old male in Medicaid hasn't had a visit. So basic risk score with age, gender, and Medicaid is 0.72. So Medicare expects their cost to be $6,600 next year. Well, Mr. Smith is actually much sicker than that. Another doc had the same patient and did code the diabetes with complications and rheumatoid arthritis, so 1.2 is the expected risk adjustment factor, and the expected cost of care is 11.2 for the next year. Whereas a third physician for the very same patient went ahead and was more comprehensive, more precise, coded systolic heart failure, chronic kidney disease stage 4, and got the secret sauce, which is disease interaction between several different combinations. For this physician, the patient's real risk score is 2.5 and expected cost of care is $23,000. You took care of this patient for a cost of $14,000, you look brilliant, and you'll get rewarded for that. You take care of this patient for the same $14,000, and it looks like you're really spending a whole bunch of money and resources the patient didn't deserve and didn't need, right? You write this one patient at a time every day until over the year your population has a risk score that's associated with your care, quality and utilization. So I propose to you that actually right now and moving forward, more time and attention should be paid on the risk scoring system and the use of the documentation table, the diagnoses in the EHR than you spend auditing for 99214s, right? But it's a totally different kind of game, and there is some risk. The risk is you systematically build a process that just tells every doctor, be sure you code that thing you coded last year, you haven't coded this year. Click the button. Even necessarily if you didn't pay attention to it, or it got healed, or you didn't deal with it this year. Sutter Health paid a $30 million fee, more claims outstanding on them in California for gaming the system for HCC and getting more money from their Medicare Advantage payer than they were entitled to. So a lot of compliance eyes on risk coding. And so the name of the game is to be precise, accurate, complete. Document everything you did for the patient and code everything you documented every day. And pay as much attention to that as you do your E&M code. Okay, observation number 5. Good grief, it's data. And we're all familiar with our impact of data in our practices and the series of emotional steps we go through. Paul Grundy, who's called the godfather of patient medical home, while he was the world director for healthcare services for IBM at that time, he came to the AFP in 2002. I was the chair of healthcare services and quality for AFP, and he sat in front of us and said, we're getting crap for what we're paying, and it's costing a lot of money in the U.S. compared to everywhere else in the world. I've got 600,000 employees, and I know their quality in every other country. In the U.S., it's crazy expensive and it's terrible. There's got to be a different way to do this. Let's talk about how to make primary care the medical home for our patients in the United States. He started the whole revolution. And one thing he said at that meeting that has stuck with me ever since, and I find myself stuck on the horns of this dilemma with partners virtually every day, which is for a culture to be ready to be grounded in data, It has to be ready to not be grounded in autonomy. And again, let that soak in soul deep, because you have to go where the data takes you. This gives us tremendous cognitive dissonance. I'm working my tail off, my heart and soul out for my diabetics every day. Yet my uncontrolled diabetes higher than A1C, higher than 9 score is 40%. I'm not being very good at it. What does that mean? Okay? It makes us revise, is essentially part of our sense of identity and what quality of me means, right? But we have to take it on. Okay? So we go through this, and your partners go through this, and unfortunately it's an individual process, one at a time. And the denial, that's not my data, this isn't right, your report broke. Unfortunately with EHRs and upgrades, sometimes they're right? Those in psychology know that's called an intermittent reinforcement schedule, and it's really hard to break that cycle. That one time 12 years ago, the report was broken, but not since. Then you get the measure is terrible, how dare you? I don't agree to measure by that, that's not, etc. You get the depression, well, okay, it's hopeless. This is where I get my patients are non-compliant. It's not my fault, it's my dumb patients. Well, there's lots of things to talk through there, right? But in value-based ecology, where patient engagement is how you win, a non-compliant patient is only a patient that has a different agenda than what you understand. Their agenda is not your agenda. Maybe our job is to understand the patient's agenda today, which may not be take my pill. It may be about not getting beat up or something. Bargaining. Oh, that's not fair. I just need more time. This is terrible. Pick a different measure. There's all kinds of bargaining. And lastly, acceptance. Golly, the data is real. It does reflect reality. We can do something about this different and do better for our population, our community. And I do find that as much as I would like to move the whole culture through the stages of grief about data at one time, to the degree you've always got staff and doctors coming and going, and maternity leave and retirements and new faculty coming, you'll take this on person by person. Observation 6, culture eats strategy. Famous Peter Drucker quote. And it has never been more true than my journey to value-based care. And my fear is this is the event horizon, this is the existential risk we face right now in primary care. Because the river has moved. There is no going back, there is no pausing, there is no, I'm going to keep my head down and paper charts and dictate and just take care of room 1, room 2, room 3 and let this all pass. It's not a blip in the road like the gatekeeper model in the 90s. And we've got to change our culture. Too many of my partners still see their job as only patient in room 1. And the stuff that happens, patients they're not seeing this month, it's not their problem. And that's a bad, bad danger for us as a specialty. So culture, we know, is a way of thinking, behaving that exists in a place of organization, beliefs and customs. I want to point out that physicians have a culture, and it crosses all specialties. I think it's both selection bias in medical school and then training in medical school. But the professional model we're trained in is completely autonomy decision-making. Self-defined process. I define what success is, and success for this patient is different than success for that patient. This patient I want an 8.0, that patient I want a 7.5. We have a short time horizon. I make the decisions when I make them today and I move on. There's few boundaries. Everything arises from self. Actions arise from self. I'm self-motivated, and improvement is just, I'm going to go to another conference, I'm going to study, I'm going to work harder. Okay? Walter Deming is kind of the grandfather of process improvement in America, and he says working harder is the worst possible plan. In clinical systems model, which is what value-based care is, the healthcare system, working with payers, working with the data, it's all clinical integration. It's all about group decision-making, an objective definition of success, long year time horizon. It's about unified goals, and improvement is to define, to measure, and improve again. The things that make us great docs, compulsive, high need for autonomy, we resist control. I'm sure that's not true here, it's just true with my docs. Self-esteem is through working harder, and we're a little criticized, a little sensitive to criticized. We share our quality data transparently every quarter, and that doesn't always go well. Unfortunately, the same personality traits we select for that make us great docs make us struggle in trying to work in a big system like the value-based care system. The tool famously said we need to pay doctors For pit crews, we're still training cowboys by and large. And this is, as I said, kind of my existential worry. There's also been a real movement that we're still often acting like we're in a service industry when really we're in an information management industry. My job as a doctor is not to be the repository of all knowledge or data. Computers do that really well. My job is to help the patient with wisdom, insight, experience, understanding, and engagement. When the patient brings in their 10 pages of internet research, you rejoice because you have an engaged patient who's trying to manage their health and asking for your guidance. That's not the usual reaction in practice, right? I find that new family physicians are in general not prepared for value-based training. So we've hired 25 residents. I've hired 25 residents into practices in the last 3 years, from 5 different states, a bunch of different residency programs. And in general, they all struggle in practice to understand how to work with a team of professionals who have passion and devotion and smart minds for population patients. They want to make every decision. Have problems with data every time. And it's like every new doc, I have to spend the same 6 months training about, this is a standard quality measure. It's a national definition. You don't get to change it just because you want to. So they come out expertly trained for medicine. What happened in the exam room in general goes really, really well. But it's working with a big system. Often, I understand here you do use PAs or nurse practitioners. Often they're lacking experience with mid-level providers in their evaluate team, lacking interaction with behaviorists, interacting with patients and bad mental health problems. That's the secret sauce to our primary care teams, is putting behaviors with every body. So I think what we train and how we train family medicine residents is going to have to change and adapt, not take away, but add some more capabilities moving forward. It's not in the RFC currently. In observation 7, we must really embrace population health. We know this on an academic perspective, but remember, value-based care, to pay us what we're worth to our communities, isn't going to cut the neurosurgeon's pay in half next year. It's going to come from all the money we're spending on the sickest of the sick and do better. There's more than enough money there. Top 5% spends 50% of every healthcare dollar, right? So we need to understand who those are in our practice. Who are my patients? Been to ED more than once, been to the hospital more than once, or have advanced disease that are going to need expensive stuff, and treat them differently. That's a little, I don't want to treat patients differently. Every patient is valued. Every patient we treat the same, which is amazing. So that way lies danger, because your COPD patient that's been in ER 6 times this year needs to be treated differently. That's advanced care management, that's in front of the behaviorist, that's a visit every 2 weeks until you get them stabilized. It's different care, right? And so that's how this lands. Lastly, this idea about population health is we're focused on the 10 or 20% of care outcomes, right? That's what we provide. That's what we want to sell, is healthcare. But if all of our revenue and our compensation moving forward is based on outcomes involves social factors, social determinants of health, health behaviors, things we have not really taken ownership of. And there's ways to do that, right? You don't have to do it all personally, but you do link to community agencies, community resources, all those things. And so for a value-based economy, where you're all about health outcomes and cost, we have to own all the things that contribute to health outcomes. And there's lots of unexplored territory there. And one bonus observation, and I'll be closing, we must sequester postgraduate training money. There are people in this room that know way more about this than I do. But in talking with both Rick Kellerman and Doug Henley just about this talk and what some of their high-level concerns are, they both expressed this in virtually identical words. If you're in a value-based health stream and you're the CFO, you've got money coming from Build Care, you've got capitation coming, you've got quality bonus payments, a couple million here, a couple million there, you've got residency training money, it's just entirely too easy for the indirect GME funds just to be yet another revenue stream that's fungible and shiftable. If it's a down budget year because our risk score is low, our quality metrics didn't quite get it, it's really easy to say, well, we lost 10 million over here, we're just going to take that 10 million from this other stream, right? It's all numbers on the spreadsheet to the CFO. So somehow, as we move into this value-based world, we have to do something special to protect the indirect GME funds. I know of that exact scenario happening at 2 different universities, so I don't think it's a theoretical risk. And lastly, Don't mean to close on a downer, but my friend Mr. Deming said, and I take this to heart some days, you don't have to change. I'm sorry, Tom, I know your quality metrics are depressing. You don't have to do anything different. It is true that survival is not mandatory. But unfortunately, in family medicine, we are poised to thrive and take our full place on the stage for healthcare. I will do some prognostication, which is, and these are not my numbers, these are from a whole variety of sources and authorities, that my system is seeing hospitalizations down 8% year over year. Okay, that is freaking hospital presidents out. It's probably over the next decade. What does it mean to your 12 hospitals, 16 hospitals? If inpatient bed days goes down 10 or 12 or 15%, what does that mean? Procedural services shifting strongly to outpatient stuff. You used to go to the hospital for, you're not going to anymore. From the patient's perspective, from the payer's perspective, think about value. You built your entire system inside or attached to the hospital because you're driving the higher fees. That's just a higher cost for no added quality or value. That's going to go upside down very quickly. Primary care services delivered by a non-physician team member. That's advanced primary care. I have a behaviorist, I have a pharmacist, I have 3 care managers, I have 2 nurse practitioners I work with. We care for 3,000 patients. Doctor at Burns MIP doesn't need a doctor visit. At best, that's a nurse practitioner visit. It may be a nurse visit following the protocol on outpatient UA, right? No fever, no obvious other systemic signs. So the way you take care of your patients in your population, even the ones that aren't coming in, is you free up time for the doctor to do stuff besides room 1, room 2, room 3. And that's challenging. And lastly, I do see primary care splintering a little bit. I don't think we'll lose our identity like internal medicine did, but I see us moving into different tracks. And this is happening. And I think direct primary care is a perfectly logical, supportable, understandable response to the pressures you're in, which is, I don't want to manage a team of 15 people and 2 nurse practitioners and a behaviorist. I just want to see my patients, myself, every day make every decision. Unfortunately, that is kind of the model we still train. And that DPC makes perfect sense. It's great care, patients love it. One doctor takes care of 600, 700 patients at a time. Sometimes you hear about big DPC practices are 1,000 patients. We're 20, depending on his number, we're 20,000 primary care doctors short already. If everybody's panel goes from 2,500 to 700, it takes us 4 decades to catch up. I do believe their argument, it's better practice, more students will want to do that type of practice. I believe that. That's a 20-year time horizon, right? So as a system builder, feel obligation to my community more than just my patients. I can't build that community-wide, right? So the other way it goes is advanced team-based care, where you have, every doctor has 1 or 2 mid-levels. You have a behaviorist, you have 2 nurse care managers, you have a health coach, you have organized, group visit care for smokers. They'll have a great smoking cessation history here. You have group encounters for diabetics where they teach each other. All those things is how you manage a big population. We dive into palliative and hospice care. I think we're all there about that. We manage transitions across sites. At least my system, 40% of readmissions happen by day 7. The old, leave the hospital says, call your family doctor, get an appointment in 2 weeks, failed from before they leave the hospital, right? So how's that handoff managed? How's your culture trained? I know you just had a knee replacement. The orthopedist is seeing you in 2 months. I still need you to see me in the next 3 days because there's other stuff going on, right? Choose opportunity wisely, and not choosing is still a choice, right? And then pick your partners. No system can afford to own everything in this value-based ecology. You've got to have partners, and usually it's community agencies, it's that sort of thing. This is a fantastic article that showed us the way forward, I think, from a practice perspective, me and my team and my patients. This is the roadmap of how you do value-based care and have a better quality of practice. And remember always, as you're moving from here to there, the fastest way between 2 points is a winged cheetah. So, with that, I'll close. Thank you very much for your time.
We have time for 2 or 3 quick questions.
Thank you, that was just amazing. For Monday, how do I help the consumer who knows I'm doing the 21 hours a day, but also needs it to be cost efficient and timely, and she does want as much expertise as I can give her in her Monday morning visit at 8:30. How do
How?
I help her when she's there for her
Right.
preventive visit,
Right.
but also does need her refills and other things? And I've got a maximally efficient team. All the labs are back,
Mhm.
and she's got questions, and I want to give her answers.
Absolutely.
And I'm not trying to be so negative.
No. That is, the theory's easy. Putting it in practice and operations is hard, which is what I've kind of spent the last 15 years trying to do. Most of what I've learned from flame out failures. You do it by offloading what's not doctor work. So there's a tremendous amount we do every day that doesn't need doctor brain or doctor training. Find someone else to do. Most often, those people don't exist in our practices. If it's you and 2 medical assistants, there's not the right person to do all the stuff that you need to not do. But free up time by carving out non-doctor work to someone else. They take training, they take hiring, they take training, they take protocols, all that's doable and knowable. You make your schedule template so that you always have time to invest comprehensively in whoever comes in. So they're in for the sore toe and a hypertension refill, but you're also hitting their prevention, their comprehensive coding, their immunizations, their risk gaps, essentially every visit you can. It kind of means the whole schedule, is it an acute visit, is it a chronic disease visit, or is it a wellness visit? That whole concept just kind of goes away. It's a visit, right? A lot of our docs have moved to standard, every visit's 20 minutes. For the internists, sometimes they have 30-minute visits. It's just one length. You're not triaging because you're doing the same stuff for everybody no matter what they showed up for. And it's a lot about, I think urgent care is an opportunity that we carve out urgent care and have a different work stream. Understand you have an urgent care in the building. We have, of my sites, 2 nurse practitioners. One of them has an empty schedule, same day care every day. The acute walk-ins know they come in. It's made our urgent care use quality metrics plummet just because they can come in every day and get walk-in care. It also means my schedule, the other nurse practitioner schedule, is much more predictable every day because it's full. We're not having to carve out spots to accommodate and double book and triple book, which causes a lot of friction and communication problems. So, good question. One other?
I'm Liz Baltaro, class of 2015. Clearly you have a lot of experience in your system, and I wondered if you would mind sharing in your own system the specific example about how you incentivize doctors to kind of adapt to this when their training makes them kind of resist, everything about so if you could at least share the specific examples that you
First of all, to say, that's a great question. So the question was, is share an example of how we've kind of tried to operationalize this. And the answer is, it's a journey. We're not there yet. We're on the road to there, right? We're riding the winged cheetah. First of all, we've got a path where we're clearly saying fee-for-service RVU compensation for the provider level is going to be declining from 85% where we've been for a decade down towards something like 60% over the next so many number of years, while non-fee-for-service quality panel supporting a team is increasing as a percentage. We carve out time. There's 2 hours a week, staff on the clock, no patient scheduled, 14 meetings. So we have time every week to staff the complex behavioral health patient, the complex care management with nurses. You all use social workers, we use nurses for complex care management. Make that important enough time, staff are on the clock, it's part of their job, is to get together and staff those big issues that spend a lot of money. We do use standard quality metrics. We continue to change and adapt and adjust. Currently our goal, for the compensation goal for the hypertension quality metric is 67%. Next year we're upping it to 70%. So have a track record of your metrics ratcheting up to get to the quality success you want. We started with, 4 years ago, our success on the breast cancer screening metric was 55%. Nobody's definition of great quality for breast cancer screening. And through that systematic kind of process, we've gotten up to 77%, trying to get to that 80% threshold. I think behaviorists, and I know everybody here sings the behavioral health song, but getting behaviorists in every primary care office, we have 25 sites, we have behaviorists in every office, essentially has been the killer app that everybody understands, everybody uses, made a difference in workflow every day. Because, what's the research? You all know better than I do. 1 out of every 4 to 5 patients in the office today has a DSM-5 diagnosable disorder, whether I caught it or not. Suddenly there's a place to take those patients and a team member engaged in your care, and that makes a huge difference. So I guess those are 3 things.
I think in the interest of people being able to have some one-on-one time and a break, we're going to put a bookmark. There's a lot of people. We have a special way of thanking our guest, and let's see. Brad, where? Thank you. Bottle of water.
Thank you.
It's actually a present. I'll let you open it up, and then we'll reopen it.
Isn't that the prettiest color bow you can? If it can't be crimson, it's pretty good.
We'll open this up. And I think one of the things that I've heard, and we will begin to hear again, I think Tommy Kuntz will be starting out. We're going to start actually at 1:35, be back in just 5 minutes past the time. We'll keep opening. Keep opening. Yeah. You got a job here.
Yeah, I'm being set up, I can tell.
Is that disruption of existing paradigms, but there's also a constancy, which is that there's only 24 hours in a day. However many hours we choose to work is constant. And that constant of time, there's also constancies of other things, art, things that reach out to us in different ways. And so we want to say thank you to coming. We also want to reach out to those other things that are constant in life. And so open up here.
Looks like something I can break easily.
It is.
Maybe I should let you.
So we don't give out plaques for this particular lectureship, but what we do give out is a clock. And on it, it's a Simon Pierce clock, a piece of glass sculpture that says, Terry Lee Mills, MD, 2019 John Henley Lecture, Department of Family Medicine, University of North Carolina, Chapel Hill. So hopefully you can put it on your desk, you can take it with you wherever you go, and have a constancy there of what the value of your time is, and that is actually what we really appreciate.
Thank you so much. I will stand outside and talk to individuals, answer questions for as long as anybody wants to talk. Thank you.
We'll take a break for 15 minutes, start back at 1:35.